today's my topic of discussion is pleural effusion, right? So what is pleura? What is pleura? Pleura is the lining of lungs, right? So there are two layers of pleura. One is visceral and another one is parietal. So the visceral layer of pleura covers the whole visceral part of lung as well as the interlobular fissure, interlobar fissure, right? And the parietal pleura, what does it line? The costal region, the diaphragmatic region and the mediastinal region. So the this parietal pleura can be further divided into costal pleura, diaphragmatic pleura and mediastinal pleura, right? So this is the basic structure of anatomy of pleura, right? So what is the blood supply of pleura? Any idea from your anatomy knowledge? What is the blood supply, principal blood supply? So the visceral pleura receives blood from the bronchial artery, systemic circulation, right? But the parietal pleura, the costal pleura from the intercostal artery, right? And the mediastinal pleura from pericardiophrenik artery and the diaphragmatic pleura from the phrenic artery, right? So this is the blood supply of the pleura. And what about the nervous innervation of the pleura? Which is painful and which is painless? Which pleura is painful and which pleura is painless? Parietal pleura, inflammation of the parietal pleura is always painful, whereas the visceral pleura lacks significant innervation. That's why any disease that involves the visceral pleura only doesn't create any pain, right? So the parietal pleura receives nerve supply from intercostal nerve and but the peripheral portion of the diaphragmatic pleura innervated by the intercostal nerve, whereas the central portion of the diaphragmatic pleura is innervated by the phrenic nerve, right? This is an important difference. So you should keep in mind that, right? So normally a very small amount of fluid, that is around 6 to 12 ml of fluid accumulates between the two pleural, that is called pleural space. This is why this is because the action of the fluid is to lubricate the pleura. So this is body physiologically, right? But so what is pleural effusion? Excess amount of pleural fluid if accumulates inside the pleural cavity. And what is pneumothorax? Air inside. So any amount of air inside the pleural cavity is pneumothorax, whereas excess amount of fluid inside the pleural cavity is pleural effusion, right? So there are different types of pleural effusion and mechanism pertaining to the pleural effusion are also very much different. So there are mainly transudative and exudative type of pleural effusion. So I'll discuss in detail in my next slides. So what is transudative and what is exudative? Exudative means any pathophysiological change that leads to inflammation of the body, inflammation of the pleura, inflammation of the lungs or malignancy. This is exudative part. And what is transudative one? There is no inflammation, there is no destruction of the cell and there is no infection. This is rather the transudative pleural effusion primarily caused by pathological change like heart failure or ascites or nephrotic syndrome. So this is not inflammatory procedure, right? But exudative is the inflammatory procedure. So tora bol je what are the two types of forces? What are the two types of different forces according to the Stirling law? Yes, hydrostatic and oncotic pressure, right? So the hydrostatic, what is hydrostatic pressure? Very good. Blood or fluid? Outward. So the hydrostatic pressure actually is the pushing pressure. It pushes the fluid from the capillary to the outward space, maybe interstitium, maybe pleura. This is hydrostatic. And what is oncotic pressure? Yes, this is the pulling force. No, primarily the pulling force of the that is meant by the oncotic pressure is determined by protein, mainly by the albumin, right? So, if the hydrostatic pressure is more or the oncotic pressure is less, then what happens? The excess amount of fluid accumulates inside the pleural cavity. That results in pleural effusion. So, name the conditions where the hydrostatic pressure is more. Where the hydrostatic pressure is more. Yes, but before that you should say that congestive heart failure, congestive cardiac failure, where the hydrostatic pressure or force is more, and name one cause that causes decreased oncotic pressure. No, not kidney failure, but you should say hypoalbuminemia. Hypoalbuminemia, like in case of cirrhosis, chronic liver disease, where the albumin synthesis by the liver is decreased, right? So the albumin of the blood itself, amount of albumin is decreased, so that means the oncotic pressure is also less. And second one is, suppose the albumin production is normal, but albumin is excreted readily by the urine. That means nephrotic syndrome or albumin urea. So these two causes may cause the decreased oncotic pressure. So this type of effusion, that is transudative effusion, mainly caused by increased hydrostatic pressure or decreased oncotic pressure, mostly they are bilateral, because they involve the systemic cause. This is not a localized cause. So mostly these type of effusion are bilateral. And another one is hepatic hydrothorax. What is that? Suppose there is massive, what is ascites? You know ascites? Peritoneal fluid in peritoneal cavity, primarily because of chronic liver disease, right? So if there is massive ascites, so massive ascites causes increased intra-abdominal pressure. Because of that, the ascitic fluid actually traverses through the diaphragmatic pore, resulting in right-sided hepatic hydrothorax, because the right-sided diaphragm has more pore than the left side or the fenestrations. So because of the increased intra-abdominal pressure, the fluid traverses through the pore of the diaphragm and accumulates inside the pleural cavity. This is called hepatic hydrothorax, most commonly in right side. Okay. Next one is what is the mechanism of exudative pleural effusion? As I have already mentioned, the exudative pleural effusion is mainly caused by the inflammation or the infection. So the inflammation of the body may be because of pneumonia, maybe because of tuberculosis or malignancy or any other important infections, which increases capillary permeability and destruction of the capillary wall, which leads to accumulation of the fluid inside the pleural cavity. Or maybe due to impaired lymphatic drainage. Because of the impaired lymphatic drainage, the fluid accumulates inside the pleural cavity, or if the lymphatics, that is the thoracic duct, is destroyed or by trauma. So what that means, that the lymph from the thoracic duct leaks into the pleural space. That is called chylothorax, right? So this is hepatic hydrothorax. And another one is, if there is any infection directly inside the pleural cavity. May or may not be associated with the lung parenchymal infection, but solely inside in the pleural cavity infection. That leads to empyema. Empyema means pass inside the pleural cavity. And if there is any trauma due to rib fracture, any dislocated rib fracture, the sharpened portion of the rib actually hits the pleural surface repeatedly, which causes bleeding from the pleural surface and resulting in hemothorax, blood inside the pleural cavity. So this is the brief mechanism of pleural effusion due to congestive heart failure. This is because of increased, as I have already mentioned, increased hydrostatic pressure. Because of the decreased cardiac output resulting in increased hydrostatic pressure. Accumulation of fluid inside the capillary wall, the excess amount of fluid pushes the capillary wall and goes outside of the capillary wall. Maybe it is accumulated inside the interstitium resulting in pulmonary edema, or in pleural cavity resulting in pleural effusion. So what are the important clinical features of pleural effusion? তোদের কি idea? Patient কি নিয়ে present করতে পারে? Yes, dyspnea, shortness of breath. But remember that shortness of breath is not the first presentation, always not the first presentation of pleural effusion, because shortness of breath only occurs if the accumulation of pleural fluid is massive in amount, or if the pleural effusion accumulates so rapidly that it causes diaphragmatic eversion. Diaphragm ulte jaচ্ছে. That leads to this shortness of breath, acute dyspnea. And other features, what are the other features? Chest pain, right? Chest pain. So what is the character of chest pain? Mostly this is pleuritic type of chest pain. So what is pleuritic chest pain? Any idea? What is pleuritic chest pain? The name itself signifies that, pleuritic. So inflammation of the pleura. So any inflammation of the pleura that leads to pain, that is pleuritic chest pain. So what is this is a sharp chest pain, sharp stabbing type of chest pain that is mostly lateralized to the chest wall and increases during cough and deep inspiration. This is called pleuritic chest pain. So patient typically describes that he or she catches his breath, cannot breathe properly. So this is pleuritic chest pain. But remember that this pleuritic chest pain only occurs if there is any inflammation along with the pleural effusion, or the pleural effusion is mild. Because if there is massive pleural fluid accumulation inside the pleural cavity, what will happen? They will lubricate more readily the pleural cavity. So the pleural cavity কি হবে, ওখানে যদি বেশি accumulation of fluid হয়, rapid accumulation of fluid হয়, তাহলে কিন্তু pleuritic chest pain থাকবে না, because এই যে ফ্লুইডটা that এটা কি করছে যে decreases the pain, because friction of the both pleura is hampered. সেই জন্য যখন pleural effusion এর পেশেন্ট আসবে, তখন at the initiation of the pleural effusion, when the pleural effusion is very small, or after you have evacuated the pleural fluid, then only the pain will appear. বুঝতে পেরেছিস? কারণ pleuritic chest pain হতে গেলে তো দুটো প্লুরাকে কাছাকাছি আসতে হবে, ফ্রিকশন হতে হবে. If the fluid is preventing the friction, then the pain will not occur. ঠিক আছে? So chest pain, and pain may be localized to the area of involvement, but occasionally pain may be referred to the ipsilateral shoulder joint. Why? Why? This statement is correct or not? এই লাইটটা বন্ধ করি, লাইট এখানে কোনো লাইট বন্ধ থাক, ঠিক আছে, ছেড়ে দাও, ছেড়ে দাও। Why ipsilateral shoulder pain? Referred from which area? I have already mentioned in my denervation section. No, this is because of involvement of the diaphragmatic pleura. Because central part of the diaphragmatic pleura is innervated by the phrenic nerve, which also give the innervate the this is called referred pain, right? So any pathology or pleural effusion that involves the lower portion of the lung, the pain from that lower portion of the lung may radiate to the tip of the shoulder. Yes, cough mostly dry in nature, but may be productive one if this is associated with any infection. Examination part. So তোরা কি ক্লিনিক্যাল ক্লাস করেছিস কেউ? প্লুরাল ইফিউশনের পেশেন্ট দেখেছিস? ঠিক আছে। So examination, there are 4 points of examination of chest: inspection, palpation, percussion and auscultation. তোরা ফার্স্ট ইয়ার থেকে জানিস তো এটা? So inspection may reveal bulging of hemithorax. The involved hemithorax may be bulged out because of the accumulated pleural fluid, and also there may be decreased movement of hemithorax. This is because of the accumulated fluid. Yes, dilated vein of chest wall may be seen in certain conditions. জানিস এরকম কোন কন্ডিশন যেখানে dilated superficial veins থাকবে along with effusion? কোন আইডিয়া আছে? So if there is superior vena cava obstruction along with one mass and effusion of upper lobe, that may cause dilated superficial vein because of the azagus and hemiazagus system যে collateral circulation develop করে বলে, ঠিক আছে? This is called SVC obstruction. So palpation may be decreased movement of the affected site because of the restricted movement of pleural cavity as well. Local temperature may be elevated, but in certain conditions. Elevation of local temperature implies there is any infection of the pleural cavity, that is maybe pus in pleural cavity or maybe parapneumonic effusion due to pneumonia. The spinoscapular distance may be decreased. Vocal fremitus, এগুলো কিছু জানিস তোরা? vocal fremitus, what is vocal fremitus জানিস? ওটা ক্লিনিক্যাল ক্লাস হলে আমি বলে দেবো, যদি আমার কাছে করিস আমি বলে দেবো। So vocal fremitus, vocal resonance, both will be decreased in the affected site. Trachea may be deviated or may be central. কোনো আইডিয়া জেনারেল নলেজ থেকে ট্র্যাকিয়া কখন ডেভিয়েটেড হবে? If there is any, suppose the pleural effusion is so massive that it shifts the trachea and mediastinum to the opposite side. এটা হতে পারে because of massive pleural effusion, or suppose আরেকটা কন্ডিশন ভাব, trachea central আছে but there is massive pleural effusion, trachea shift হয়নি, trachea pleural effusion push করছে trachea কে to the opposite side, but if there is any pulling force same side যদি থাকে, suppose there is any collapse of the same side of lung because of intrabronchial tumor or mucus plug, so কি করছে ব্রঙ্কাসে যদি কোনো তোর টিউমার থাকে or any foreign body থাকে, তাহলে that bronchus actually that negative pressure pulls the trachea and the mediastinum, whereas the pleural effusion pushes the trachea. So this counteracting force actually makes trachea or mediastinum at the central position. So যদি কোনো পেশেন্টের এরকম পেশেন্ট কোনোদিন পাস, the এক সাইড hemithorax is occupied by large pleural effusion but the trachea is not shifted, then you should do a CT thorax to exclude any interbronchial pathology, right? Percussion, dullness, maybe stony dullness in the affected side, and there are two triangles that is called Grocos triangle and Garland's triad. So suppose this is the area of pleural effusion. This is the area of pleural effusion. This is dull because of accumulation of pleural fluid, but the upper part of the area involved in pleural effusion may be hyperresonant because of the compensatory hyperinflation. So এই এরিয়াটা ডাল পাচ্ছিস, জাস্ট তার উপরের এরিয়া hyperresonant, right? So this is called Garland triangle of hyperresonance. ঠিক আছে? আবার সো এখানে যদি ইফিউশন থাকে এই এরিয়া ডাল হবে, বাট অপোজিট এরিয়াটা ডাল হওয়া উচিত নয়, বাট দিস অপোজিট এরিয়া, দিস ট্রায়াঙ্গুলার এরিয়া just adjacent to the spine may be dull because of the, suppose there is effusion and the diaphragm eversion occurs. So the diaphragm কি করবে, মানে part of the diaphragm is reflected to the opposite side. এই সাইডটাতে part of the diaphragm reflect করবে এই এরিয়াটাতে. So this diaphragm causes dullness to the opposite side. This is called Grocos triangle of dullness. So any confusion, Garland triangle and Grocos triangle. Actually this is pleural effusion. This area is dull, okay, but just above the area of dullness you may find hyperresonant note because of the compensatory hyperinflation of the above area. This is hyperresonant area. This is called Garland's triangle of hyperresonance. Whereas the opposite part, in the opposite side of hemithorax, actually these signs are not obvious enough. You may not find these signs in each and every pleural effusion. Okay. In opposite side, because of the reflection of the diaphragmatic pleura to the opposite side, this area of dullness may occur. This is called Grocos triangle of dullness, right? And auscultation may reveal decreased vesicular breath sound and decreased vocal resonance. So this area, suppose this area, right? This is the Garland's triangle of hyperresonance. This is the, suppose this is a consolidated area. You may find egophony in this area. What is egophony? The E sound turns into A because of the consolidated part. E sound turns into A, nasal intonation. E sound turns into A. So this is called egophony or E to A transfer because of this consolidated area. Patient কে E বলতে বল, মানে E টাইপের সাউন্ড করতে বলছিস, তোর শুনতে লাগবে পেশেন্ট বলছে A. This is called E to A transfer or egophony. This is because of the consolidated part. ঠিক আছে? So this is the, suppose এখান থেকে তুই after clinical examination you are certain that you are dealing with a case of pleural effusion, then you have to order X-ray, right? So but what is the most sensitive investigation of this pleural effusion? That is ultrasonography, USG. So USG of thorax may detect as low as 10 ml of pleural fluid, whereas X-ray PA view may detect 175 to 180 ml of pleural effusion, and lateral view may detect 50 ml of pleural effusion. So basically একটা X-ray কিন্তু can tell you about the diagnosis of pleural effusion as well. ঠিক আছে? সো কখনোই শুধু প্লুরাল এফিউশন দেখে ছেড়ে দিবি এরকম করবি না, বিকজ এখানেই অনেক ক্লু আছে দেখ। সো this is homogeneous opacity obscuring the left, middle and lower zone, and the curvature of the upper part of the opacity is directed towards axilla, right? Just S-shaped, reverse S-shaped, and the meniscus, the upper part of the meniscus is directed towards the axilla. This is typical pleural effusion. This is not a loculated one. This is free pleural effusion. Okay. So this is obliterating bilateral costophrenic angle. The second picture, obliteration of bilateral costophrenic angle. এখান থেকে বুঝতে পারছিস এটার ইটিওলজি কি, হোয়াট মে বি দ্য ইটিওলজি অফ দ্য প্লুরাল এফিউশন? সো bilateral pleural effusion, that means it is transudative one. ঠিক আছে, bilateral pleural effusion systemic cause হচ্ছে। along with that the cardiothoracic ratio is increased, so this is because of heart failure, congestive cardiac failure, and this is massive pleural effusion, but the mediastinum and the trachea is shifted to the opposite side, right? So this is the free pleural effusion, free. The pleural fluid is free, but look at that. This is D-shaped loculated pleural effusion, blunting of costophrenic angle, but there is no proper meniscus that is directed toward the axilla, but it is D-shaped. This is called loculated pleural effusion or infected pleural effusion. And what is this? This is fissure. This is horizontal fissure. Pleural fluid accumulates inside the fissure. This is called intrafissural effusion, right? Intrafissural effusion. This is also termed as vanishing tumor or phantom tumor. Why? Because actually intrafissural effusion mostly occurs in heart failure, congestive cardiac failure, right? So after you treat the heart failure with diuretics, the next day the tumor will vanish, the effusion will vanish. So this is called phantom tumor or vanishing tumor. And what is this? কোন আইডিয়া করতে পারছিস? This is pleural effusion, typical pleural effusion, but etiology এখান থেকে just follow the continuity of the rib, left sided ribের continuity follow কর, দেখ this is continuous rib, this is normal, but এই দেখ this one, এটা দেখ the continuity is broken, দেখতে পাচ্ছিস? এই তো continuity is broken, straight line এর rib তো নেই। second one দেখ, this is the rib, this is the one segment and this is the another segment. বুঝতে পেরেছিস না বুঝতে পারিসনি? আচ্ছা দেখ এটার সঙ্গে কম্পেয়ার কর, compare the right and left. So this is the right fourth rib, this is the right fourth rib, this is in the straight line, ঠিক আছে? এবার এখানে কম্পেয়ার কর, this is the left fourth rib, and this is the another segment. This is the another segment and this is the another segment. Clear? This is because of fracture rib. The pointed part of the fractured rib actually causes hemothorax. This is hemothorax because of traumatic rib fracture. ঠিক আছে? কোনো কোয়েরি এখান থেকে কোনো এক্সট্রা বুঝতে পারছিস না এরকম কিছু আছে? আমি স্লাইডটা দিয়ে দেবো, মানে যদি এখানে না বুঝতে অসুবিধা আমি স্লাইডটা দিয়ে দেবো, এক্সট্রাটা দেখে নিস একবার, ঠিক আছে? So what will be the next step after you confirm that the pleural fluid is present? What will be the next step? Yes, you have to perform a thoracocentesis or pleural tap. How should you do it? First, you have to percuss the highest point of dullness. You have to find the highest point of dullness by percussing the thorax. So after that, sorry, so suppose this is the highest point of dullness. So always ask the patient to lean forward, because lean forward hole ki hobe, the intercostal spaces will be separated, মানে intercostal space এর সেপারেশনটা অনেক বেড়ে যাবে. So you can easily perform thoracocentesis. And also this in sitting position the pleural fluid accumulates or gravitates towards the lower portion, basal portion. If it is loculated, not loculated one, if it is free one, then the pleural fluid will accumulate at the base of the lung. So then কোথায় পাংচার করবি? Basically first you have to localize the area by percussing highest point of dullness, highest area of dullness, just 1 to 2 intercostal space below the highest point of dullness. যেখানে highest point of dullness পাচ্ছিস আপার লেভেলটা থেকে একটা স্পেস বা দুটো স্পেস নিচে করতে হয়, ঠিক আছে? আর ওই স্পেসেও করা যায়, কোনো প্রবলেম নেই, ঠিক আছে? তো এই এরিয়াটাকে কি করতে হবে? স্টেরিলাইজ করতে হবে, or by betadine or by other antiseptic solutions. Okay, next, what should be the ideal site for inserting the needle for thoracocentesis? Yes, lower part of the upper rib, right? Not lower part, because এখানে কি পিকচার আছে দেখ, in the lower part of the upper rib এখানে কি আছে? There are vein structure, intercostal vein, artery and nerve. So you may puncture that structure. So always prefer upper border, not the lower border. This is the upper border, just intercostal muscle is there, no vein structure is there. So what are the indications of thoracocentesis? There are two main indications, diagnostic and therapeutic one. So diagnostic one, you have to perform in each and every case a diagnostic thoracocentesis, except if you are certain that this is because of heart failure. Suppose the patient is having heart failure, features of heart failure, and the effusion is bilateral, or you may find the patient is having cardiomegaly, then the thoracocentesis is not needed. Okay, just treat the patient. But if it is unilateral or unexplained pleural effusion, right, or you may suspect malignancy, infection, then you should do a diagnostic thoracocentesis. And what about the therapeutic thoracocentesis? If the accumulation of pleural fluid is massive, that results in severe respiratory distress, or there is pus in the pleural cavity or empyema or infected pleural effusion because of pneumonia or hemothorax. These three conditions, in these three conditions, you must have to evacuate the pleural space as early as possible. What are the contraindications of doing thoracocentesis? Uncorrected coagulopathy, very low platelet level, less than 50,000, or local skin infection, or if the patient is in mechanical ventilation. So now thoracocentesis has been done by you and you will wait for your pleural fluid report. So what important test you should order after thoracocentesis? Cell type, cell count, protein, glucose, ADA, adenosine deaminase, LDH, gram stain culture sensitivity, malignant cell, smear and block, right? This test you should order. So first you have to differentiate from your lab value, is it transudate or is it exudate? এটার নাম শুনেছিস লাইটস ক্রাইটেরিয়া? Lights criteria proposed by Richard W. Light to differentiate between exudative and transudative effusion. Three criteria are there. First one is if the pleural fluid protein is more than that of serum protein, 0.5 ratio, 0.5. Pleural fluid LDH by serum LDH is more than 0.6, or pleural fluid LDH is more than 2/3 of the upper limit of the serum LDH. These three criteria are called as Light's criteria. If any of the criteria is fulfilled, then it is exudative effusion. Any of one criteria must be fulfilled, any of one, not necessarily all three, then it is exudative pleural effusion. So protein divided by serum protein is more than 0.5, LDH divided by serum LDH is more than 0.6, or the pleural fluid LDH is more than 2/3 of the upper limit of the serum LDH. Very essential criteria, এটা কিন্তু খুব ইম্পর্টেন্ট, মনে রাখতে হবে, ঠিক আছে? আদার ক্রাইটেরিয়া এগুলো মনে রাখতে হয় না। exudative in exudative pleural effusion, pleural fluid cholesterol is more and pleural fluid bilirubin by serum bilirubin is more than 0.6. এগুলো মনে রাখতে হবে না, বাট লাইটস ক্রাইটেরিয়া কোনোদিন ভুলবি না, লাইটস ক্রাইটেরিয়া ভেরি ইম্পর্টেন্ট। So these are the causes of transudative and exudative pleural effusion. Transudative effusion, most common cause of transudative effusion is heart failure, congestive cardiac failure. Cirrhosis, nephrotic syndrome. So cirrhosis with ascites, what does that mean? What is the mechanism of ascitic fluid accumulates inside the pleural fluid into the pleural space? This is just I have mentioned, this is hepatic hydrothorax, right? Nephrotic syndrome, myxedema coma because of hypothyroidism, or SBC obstruction, যেটা মেনশন করলাম SBC obstruction, or pulmonary embolism. These are the cause of transudative pleural effusion, and other causes are exudative pleural effusion. So most commonly pneumonia, tuberculosis, malignancy, pancreatitis, these causes are exudative pleural effusion. So this is the approach to a pleural effusion patient. Patient with abnormal chest X-ray and blunting of CP angle. If the fluid thickness is more than 10 millimeter, then you have to aspirate them. So any of one, just I have already mentioned, this is in proper diagram from LDH, protein, and this criteria, Light's criteria. If this is exudative or this is transudative. If this is exudative, then if in case of exudative pleural effusion, you have to send for malignant cell smear and block to exclude malignancy, and glucose, pleural fluid glucose, because in case of complicated pneumonic, parapneumonic effusion, what is parapneumonic effusion? The effusion that is because of pneumonia, because of the parenchymal infection. This is called parapneumonic effusion. Okay. So parapneumonic effusion or empyema, pus in the pleural cavity. In this infection, parapneumonic effusion or empyema, the pleural fluid glucose will be lower because of the high bacterial burden. The bacteria utilizes glucose, metabolizes glucose. So the pleural fluid glucose will be less. First, observe the general appearance of the pleural fluid. Is it straw color? Straw color is mostly exudative. Clear is mostly transudative. Hemorrhagic may be blood tinged. Suppose তুই অ্যাসপিরেট করতে গেলি, রাইট, বাট একটা ট্রমা হলো, বাট ট্রমাটিক অ্যাসপিরেশন হলো, just one tinge of blood, small tinge of blood can make your fluid hemorrhagic. Bloody color, bloody trap আসবে, clear হবে না, just small amount, very small amount of blood. ঠিক আছে, this is called hemorrhagic pleural effusion. This is not a hemothorax. There is no blood inside the pleural cavity, but you have done a trauma to that aspiration, so that turns the fluid hemorrhagic one. This is not hemothorax. Turbid, maybe turbid one because of the pneumonic effusion, parapneumonic effusion. Turbid means infection. Any turbidity in the pleural fluid means there is infection. Maybe pus, empyema. Milky white because of chylothorax. Chylothorax means triglyceride inside the pleural fluid, pleural cavity is more than 110, whereas cholesterol is lower. This is called chylothorax, just milky white pleural fluid, but this is not pus. Black because of fungal infection, Aspergillus niger. Odor is also very important. Urine like odor, this is called urinothorax. Rupture of any fistula, ureteric fistula, or after any procedure, traumatic procedure, the urinothorax may happen, right? Feculent in case of anaerobic infection, right? So these are the primary investigation of pleural fluid. About the cell type, there are three types of different cells: neutrophilic, lymphocytic or mesothelial. So neutrophilic, that signifies infection. Neutrophilia, that means infection. Lymphocyte may be in case of tuberculosis, may be in case of malignancy. And mesothelial mostly in malignant pleural effusion. So neutrophilic, lymphocytic and mesothelial cell. Then pleural fluid protein. If pleural fluid protein is less than 3, then mostly it is transudative. But always do the ratio of pleural fluid versus this serum protein. Okay. Mostly pleural fluid protein is less than 3 in case of transudative and more than 3 in case of exudative. And pleural fluid glucose, mostly pleural fluid glucose, in normal cases pleural fluid glucose, just level of pleural fluid glucose is same as of the serum glucose, 60 to 110 mg per dl. But if it is less than 60, then maybe you are dealing with tuberculosis, malignancy or rheumatoid arthritis pleural effusion. And if it is less than 40, then it is maybe because of pneumonic effusion, parapneumonic effusion or empyema itself. So in case of parapneumonic effusion, the bacteria actually, because of the metabolism of the bacteria, the glucose will be lower. But in case of rheumatoid arthritis, the glucose will be lower because of the transportation difficulty in transportation channel, that leads to low glucose in pleural fluid in rheumatoid arthritis. And what about LDH? Lactate dehydrogenase. So LDH is solely a marker of inflammation, right? After destruction of the cell, LDH may release from the cell. ठीक है? So in case of transudative effusion, there is no destruction of the cell, there is no inflammation, so LDH will not be higher. But whereas in exudative effusion, LDH may be higher. Second thing, LDH, if LDH itself is more than 3000, then the cause of the pleural effusion may be because of malignancy also, like lymphoma. In lymphoma, LDH value is more. ठीक? And what is ADA? Adenosine deaminase. Adenosine deaminase level is also crucial to differentiate between tuberculous or malignant effusion. Suppose the effusion cell type is lymphocytic. So lymphocytic cell type means maybe tuberculous, maybe malignant effusion. Then ADA will help to differentiate between tuberculous effusion or malignant effusion. So ADA, adenosine deaminase, primarily produced by monocytes or lymphocytes, right? Macrophages, right? So tuberculous infection is mostly driven by macrophage itself. That's why in tuberculous pleural effusion, ADA will be higher, whereas ADA is lower in malignant effusion. This is the brief management of transudative pleural effusion. Just treat the cause. In case of exudative and transudative effusion, always treat the underlying cause of exudative effusion. In case of heart failure, congestive cardiac failure, diuretics, and resolves when CHF or congestive cardiac failure controls. But if the effusion is massive one, that result in severe respiratory distress or desaturation or hypoxia, then you have to evacuate that pleural fluid by therapeutic thoracocentesis. Hepatic hydrothorax, just treat the ascites, treat the liver disease, then it may spontaneously disappear by diuretic or spironolactone salt restriction as well. Nephrotic syndrome, treat the underlying glomerulonephritis, give steroid if any nephrotic syndrome, minimal change nephrotic syndrome. Hypoalbuminemia, actually hypoalbuminemia because of pleural effusion, because of hypoalbuminemia may occur due to which disease? Liver disease, chronic liver disease. Second, in malignancy also. In malignancy, because of this chronic inflammatory procedure and malignant cell deposition, the albumin synthesis is itself lower. So hypoalbuminemia not only in hepatic hydrothorax but also in malignant effusion as well. So in that case, suppose if you find suppose right or left sided effusion in case of malignancy, breast malignancy or any malignancy, but the pleural fluid turns to transudative, not exudative. Actually malignant effusion কি হয়? Exudative হয়তো, but তুই পেলি transudative effusion, তাহলে তুই কি সাসপেক্ট করবি? This is because of hypoalbuminemia. Clear? বুঝতে পারলি? This is not because of this malignancy, this is because of hypoalbuminemia. So this is management of exudative pleural effusion. Always treat the cause, but always do therapeutic thoracocentesis if this is a case of hemothorax or this is a case of parapneumonic effusion or empyema, pass in pleural cavity. এই তিনটে কেসে কিন্তু you have to evacuate the pleural space first. Second, in case of parapneumonic effusion, always give IV antibiotic in a form of amoxiclav plus metronidazole or clindamycin. মনে রাখবি, each and every antibiotic has different penetratable capacity inside the pleural space. ঠিক আছে? So inside the pleural space, if you treat the anaerobic infection, then you have to administer metronidazole or clindamycin along with the other antibiotic, piperacillin, tazobactam or amoxicillin. So malignant effusion, actually malignant effusion arekta important effusion hoche malignant effusion. So malignant pleural effusion occurs very rapidly. Suppose তুই একটা তোর কাছে একটা পেশেন্ট এসছে, পেশেন্টে তুই প্রথমে দেখলি একটা ম্যাসিভ প্লুরাল এফিউশন আছে জাস্ট ডিউরিং দ্য প্রেজেন্টেশন, তখন তুই অ্যাসপিরেট করে দিলি, পুরো ক্লিয়ার হয়ে গেল, বাট আফটার 1 উইক আবার এসে সে কিন্তু আবার একটা র্যাপিড অ্যাকুমুলেশন আছে। এই যে র্যাপিড অ্যাকুমুলেশন অফ দ্য প্লুরাল ফ্লুইড, এটা কিন্তু সাজেস্টিভ অফ ম্যালিগন্যান্ট প্লুরাল এফিউশন উইদিন এ শর্ট পিরিয়ড অফ টাইম, ঠিক আছে। অ্যান্ড ম্যালিগন্যান্ট এফিউশন মোস্টলি আর হেমারেজিক। অন্যান্য এফিউশন যেগুলো বললাম মে বি ক্লিয়ার, মে বি টার্বিড, বাট ম্যালিগন্যান্ট এফিউশন মে বি হেমারেজিক। তুই ট্রমাটিক না করেও কিন্তু হেমারেজিক হতে পারে, ঠিক আছে। দিস ইজ ম্যালিগন্যান্ট এফিউশন। Pulmonary embolism, rheumatoid arthritis and pancreatitis related diffusion. Treat always so এখানে pancreatitis related diffusion, pancreatitis থেকে কিভাবে diffusion হতে পারে? চান্স আছে কি হওয়ার? হতেই পারে, because pancreatitis, there are two types of pancreatitis, acute and chronic. Suppose if there is acute pancreatitis, pancreas is just the relation of the pancreas is just below the diaphragm, ঠিক আছে, মানে বেসিক্যালি টেল অফ দ্য প্যানক্রিয়াস ইজ কিছুটা পার্ট তো এতে থাকে, বিকজ মানে নট নর্মালি বাট ইনফ্লেমড প্যানক্রিয়াস, সো দ্য ইনফ্লামেশন অফ দ্য প্যানক্রিয়াস ইরিটেট দ্য ডায়াফ্রাম, সেখান থেকে ইফিউশন হয়। সো ইন অ্যাকিউট প্যানক্রিয়াটাইটিস, প্যানক্রিয়াস কোন দিকে থাকে, লেফট অর রাইট? লেফট তো। সো ইন অ্যাকিউট প্যানক্রিয়াটাইটিস there is chance of left sided diffusion because of the inflammation of the pancreas that irritates the diaphragm, ঠিক আছে। But bilateral effusion may also occur because of the other diaphragm irritation. আর একটা chronic pancreatitis এও কিন্তু left side effusion হয় because of pancreatopleural fistula. Repeated pancreatitis যখন হচ্ছে তখন pancreas and pleural cavity এর মধ্যে একটা fistula ক্রিয়েট হয়, ঠিক আছে, সেটার জন্য কি হয়, ক্রনিক ইফিউশন, প্লুরাল ইফিউশন হয়, ঠিক আছে। ঠিক আছে, কোনো কোয়ারি এখান থেকে? ভেরি এক্সটেন্সিভ লেকচার, তাই না, প্লুরাল ফ্লুইড, প্লুরাল ইফিউশন। যখন ক্লিনিক্যাল এক্সামিনেশন করবি বা যখন কেস নিবি, মানে অ্যাকচুয়ালি প্লুরাল ইফিউশনে তো কেস থাকে, তোদের শর্ট কেস থাকে, তো তখন কিন্তু আরো জিনিসটা ক্লিয়ার হবে। এই যে ইনভেস্টিগেশনস গুলো বললাম, এইভাবে যে এক্সামিনেশন গুলো, এগুলো কিন্তু ক্লিয়ার হবে, ঠিক আছে।